Good afternoon, ladies and gentlemen. I am glad to have the opportunity to share my current study. The topic I will introduce today is new insights for obstructive sleep apnea with upper airway muscle dysfunction. It's a kind of a narrative study, and I will use OSA as the abbreviation for obstructive sleep apnea for today's presentation. I will briefly introduce OSA first. OSA is characterized as partial or complete upper airway obstruction during sleep. We also called hypopnea and apnea. And the diagnosis in clinic is examined by sleep test. We also call the polysomnography, a kind of multiple physiological signal examination, including EEG, ECG, respiratory rate, and the others. The clinical signs of OSA include intermittent hypoxia with oxygen desaturation, a high prevalence of comorbidities, considerable impairment of quality of life. The severity of OSA defined by the frequency of apnea and hypopnea per hour during sleep test. We have different options for OSA management, including CPAP and surgery and the others. Even though the CPAP is the first-line therapy, in spite of low compliance, there exists an emerging therapy beyond CPAP. We will introduce this new intervention for OSA today. The pathogenesis of OSA can be determined by anatomical and non-anatomical factors. Soft tissue surrounding pharynx are the important anatomical factors resulting upper airway collapse, such as tonsil or tongue-base hypertrophy. Oropharyngeal muscle dysfunction is one of the most common non-anatomical factors. The respiratory drive from medulla oblongata critically dominates oropharyngeal muscles to counteract the increasing negative intraluminal pressure during inspiratory phase. If the oropharyngeal muscle can be activated to maintain the upper airway patency, we call it good muscle responsiveness. Otherwise, it would be poor muscle responsiveness. Thus, upper airway muscle training become an emerging therapy beyond CPAP to manage the upper airway obstruction during sleep. The meta-analysis from our previous study found that the upper airway muscle training can improve 39% AHI from baseline. Additionally, the study also concluded the program for upper airway muscle training should be anatomically based with multiple level approach. The results from the study also demonstrated that the intervention of upper airway muscle training indicated for OSA with mild and moderate cases only. Then, three further questions raised from the previous study. We proposed these three purposes in the study. The first one is how does the upper airway muscle training work for OSA? The second is why does it include a multiple level approach? The third is why does it indicate for mild and moderate cases only? We searched for OV, Central, Embase, and the Google Scholar conducted the narrative study question by question to summarize the key concepts related to upper airway muscle training and interdisciplinary perspectives, including biomechanical basis of oropharyngeal muscle, neurobiological foundation of sleep medicine, physiological mechanisms of respiratory loop control. The EMG study showed the different muscle activity during different sleep stages. From this graph, we can see the tongue activity compare the wakefulness, the respiratory drive withdrawal during sleep from non-rapid eye movement stage to rapid eye movement stage. And this situation will become worse among OSA population. That's the reason why the upper airway will collapse during sleep among OSA population. The biomechanisms of upper airway muscle training is designed to re-educate the oropharyngeal muscle activity and to reshape the oropharyngeal patterns. From this graph, we can see the genial glossus muscle can protrude the tongue. The levator palatal muscle can elevate the uvula. The palatal-glossus muscle can enhance the tongue tightly to the mandibular floor, and the palatal-pharyngeus can dilate the hypopharyngeal space. And another medical image study showed that OSA was found to be multiple level collapse of upper airway. The palatal collapse occurred most frequently, 81%, followed by the tongue base collapse, 47%, and the hypopharynx collapse 39%, suggesting the upper airway muscle training should emphasize a multiple level approach to specific regions, including retropalatal, retroglossal, and hypopharyngeal level as well. In addition to anatomical deficits such as adenotonsillar hypertrophy, 64% of OSA patients were identified with more than one clinical trait, which makes it approach is considered a feasible option to manage the residual sleep breathing problem instead of upper airway muscle training alone. It is also implied that while the previous single approach via upper airway training could apply for mild and moderate cases only. To summarize the topic today, we have three key points. The first, upper airway muscle could be a new approach for OSA with oropharyngeal muscle dysfunction. The second is the upper airway muscle training should focus on multiple level approach for collapse at different sites. Third, as an emerging precise medicine should combine the different therapy according to mixed clinical traits. And it's the end of my today's presentation. Thank you for your attention. Your question, comment, and suggestion are surely welcome.